I gotta make sure. I got a software update and it messed things up. So I want to make sure the settings are proper. We're good. Very good. So on with the show. It's a great chapter to end. AMP1. I don't know you're going to have for AMP2. I think Mrs. McGran is teaching a couple, and Dr. Maurer is teaching a couple. It's Dr. McGran. She's actually a medical doctor. She's very smart. They're both wonderful, very, very bright. So whatever you have, they'll be good. Like I said, and I'm always here if you have points of clarification. Shoot me an email. Happy to help. So this is a really good chapter because it brings everything together. This is really what homeostasis is about. Autonomic nervous system. It is a relatively simple anatomic system. It has a lot more complexity physiologically. It's got a two-nerve circuit. You have a nerve going from either the brain or the spinal cord. It has a synapse. It's got a bundle of them all in one place. Because it's outside of the central nervous system, we don't call it a nucleus, we call it a ganglia. We have a fancy way of naming the nerves. We call them before you'll see this in illustration, pre-ganglionic and post-ganglionic. The nerve that's leaving the brain or the spinal cord, where it meets the other nerve, we call it ganglion, we call that the pre-ganglionic fiber. And where it goes from wherever its target is, typically an organ, okay, is the post-ganglionic fiber. It's a very simple system anatomically. We just got started. And it's really where it's significant. It depends on where your course of endeavor is. If it's in nursing or if you're heading toward nursing or in health sciences, effectively we treat the human body by way of this system. Many of the medicines for blood pressure, for heart, for kidney, for respiratory are related to this system. You're going to see this is a system where we learn the magic of the EpiPen and why it works. Come on, we're just getting started. You all set? That's good.
Thank you
very much. So we'll get everything in. It's just such an interesting system. So again, for you folks who just got here, the final is here next week. I'll send you a list of other times that I'm around. If you're interested, and also on Monday, my 9, my 11, my 9, my 10, and my 1 o'clock, which are all the same course, I'll be doing review sessions. Just saying. So autonomic nervous system, you can say automatic, innervates other than skeletal muscles. This innervates basically everything else, your heart, your lungs. When they say smooth muscle, all of those tubes that can open up and close like this or open up like this, it's about smooth muscle. So we can redirect flow of blood. We can direct flow of material by way of these tubes. We can't consciously do it. How do we do it with medicines? That's why this is such an important area regarding medicine itself, why it's so terribly important. That's where pharmacology is. You're going to hear some names like alpha 1s and beta 2s. That's really the kinds we name the receptors. And again, it's relatively straightforward anatomically. So, and it's all about homeostasis. We need it to go to certain places to do certain things. That's just a construct of the darn thing. And so it's subconscious, or we call it involuntary, and the heart, the blood pressure, digestion, blah, blah, blah. It's technically part of the peripheral nervous system. It has two divisions, sympathetic and parasympathetic. The sympathetic, we'll see if one of these works. Sympathetic system, it does, yay. Called the action division. All you need to know to understand these two divisions is what this one does, Vizian. This is called action. It goes from thoracic 1 all the way to L2. So we call it thoracolumbar because it's from those two nerves coming from there. And basically, the closest thing we have to these divisions basically tug against one another, push and pull against one another. They call it a dynamic antagonism. It's very nicely stated. What it's all about is homeostasis. Blood pressure went up, oh, you're low. Went up, you're low. adjusting a little too fast, slow it down. Up, not fast enough, speed it up. It's fight or flight. Using the same example that I always seem to use, with regard to examples, is that it's color. Because again, that idiot who cuts you off. That's your nervous system. Okay? That's fight or flight. At that point, you have redirected everything for action, or whether you're just going out and go to the gym for a workout. You're going to run out because you found something, you forgot something in your car or over your dorm room. You're running back. All of a sudden, everything is dedicated to either fighting or running away, doing something rapidly. And your eyes are wide open so you can see. Your respiratory passages are wide open so you get maximum oxygen. Your heart's redirecting, your brain is redirecting your blood flow to the heart, to your skeletal muscles. It's opening up your respiratory passageways. It's drying up your mucus and other secretions so you have maximum air to breathe. And it's taking that blood flow away from where you really don't want to use it at this point, where it usually goes when you're just sitting here like you're doing now, or at rest or sleeping. And that is from the gut, the gastrointestinal, and from the genitourinary system. Where sitting here now, that's where the vast majority of your blood flow is going. All the other areas get what they always get. Brain gets the same amount of stuff. That's what this is all about. So if you remember what those things do, that's the closest thing we have to pure sympathetic. It's that. So if you remember the opposite, because a lot of the way the questions are stated is in fight or flight, what do your eyes do? They dilate. In fight or flight, what does your heart do? It increases. And when sympathetic division, what does it do? You know, it picks up, increases respiration, dilates little bronchioles. We're going to get to all of that. And see if you remember what that does, and it's easy to remember. Just think, happens when I really have to get when, oh my God, somebody's chasing me. Or, oh my goodness, my kid's running into the street. And all of a sudden, you're in action. All of that, and the opposite is parasympathetic. Mostly they're both active simultaneously. That's the rare instance where they're not. Parasympathetic we call rest and digest, because it's really a lot about digestion. Interestingly, it's cranial. 4 cranial nerves rather. 3rd, 7th, 9th, and 10th. And the 10th is the biggie. That's the vagus nerve. It's the only one that leaves the head and neck. You might remember from cranial nerves, and goes everywhere. Innervates your lungs, innervates your bronchi, innervates your digestive system. Big one. Spleen, liver, pancreas, whatever. And the other part is the sacral division. Generally sacral, it is, so those are cranial nerves. Sacral is S2 to S4. And interestingly, that division typically takes care of things like the bladder and the ureters and plays a pivotal role in reproduction. And that's really where the two of these marry together very, very well in reproductive physiology. Because even though this one doesn't go into the sacral area, the nerves do. Those are the 2 major divisions. And on with the discussion. Oh my God. Long day. Nothing like shoveling snow the first time. Moving on. Okay. So I skip a lot of this. We're going to talk about how the fiber is different a little bit anatomically and where they target. Most of the time it's about the neurotransmitters. You really are way ahead of the game because the principal neurotransmitter for both of these systems is acetylcholine. That's the one you know the most about. The other major one is norepinephrine, and that's fairly straightforward. So it's not as complex. The complexity is in the receptors. What they do at different, because they don't do the same thing in every receptor. Most of the time they're excitatory, but sometimes they're not. And it's those exceptions you need to remember. Let's see. So somatic means like move your skeletal muscles. Autonomic, again, reiterates cardiac, smooth, and glands. I'm sorry already. We use these terms. I have to teach them to you because if you're taking a licensure exam, they are probably going to use those terms with a question on autonomic, called preganglionic and postganglionic. Again, where they come together is called the ganglion because there's a bunch of them, and it's outside the central nervous system. You're going to see this, you might as well get stuck with it now. The sympathetic system has short, I'm just going to put pre-ganglionic fibers and long post. So however you want to remember, sympathetic, long, pre, short, post. Parasympathetic has long, pre, short, post. Yeah, there's no easy way. The vagus nerve is named because it wanders. Originally, it's named because it took the Latin from vagabond, shortened to vagus. When it goes from your head and your neck all the way, all your internal viscera, the whole digestive tract, your bladder, okay, all those things, sexual, etc. It's all over the place. So it has very long preganglionic fibers and very short post ones. They're basically at the target by the time that ganglia, so typically the ganglia is in the target already. That's one of those things, that's the old just because, Roy, just because you got to memorize. Sorry. I don't make this, I wouldn't have done it this way. I would say first and second, easy. But they don't let me change it. We know the neuromuscular junctions, acetylcholine, preganglionics or acetylcholine, and all of them, whether they're going sympathetic or parasympathetic, postganglionics are norepinephrine if they're in the sympathetic, or acetylcholine in the parasympathetic, with an exception or two. Getting there. And basically, it depends on the receptors, whether they excite or they inhibit. Yeah, coordinated. Yeah. I mean, this is what happens. That's what fight or flight is. It involves skeletal muscles, and so the systems are combined and they work coordinatedly, but only one is under conscious control. So when you're saying, I got to run and chase this down, yeah, I'm activating my muscles. Now, the other systems I don't have any control over have to compensate. That sympathetic nervous system, oh, what the hell did he forget now? That was me yesterday on Monday running up and down here. My phone got buried in between the seats in my car. My interior is black. The next cell phone cover I get is not going to be black. Sorry. My son, my eldest, is convinced it's all over. I'm losing. I'm going to be in the nursing home next week. He's convinced. He called me from England already. He's in London for a few days. We're here in this effing weather, and he's enjoying himself in merry old England and the government's tab. The Navy's looking for some kind of engineering technology and seeing if it's compatible with the shipbuilding. That's as much as he could tell me, because it's anything else I'm sure is classified, but that's the generic stuff. I'm like, and they didn't even fly him over in first class. Sorry, he must have been very upset. Agreed. He went to England. I was at Sam's Club yesterday. So moving on. So these myelinated, the only ones you have to worry about myelin are skeletal. And we talked about that, and we talked about myelin vis-a-vis the final exam. But these are effectively don't have myelin, don't have to worry about it. So you can see a preganglionic fiber, and here's one of the oddballs. Of course, not talking about long or short. So in the sympathetic nervous system, acetylcholine is released, and almost always norepinephrine. One of the oddballs is here. This is the adrenal gland. Your adrenal gland, you're going to learn about an endocrine shortly in AP2. The exterior portion, like all things, just like in bone. You have cortical bone and you have medullary bone. Cortex is on the outside, medullary is inside. The cortical area is an endocrine gland. It's where we make corticosteroids. Okay, those are under the control of the endocrine system. Even though you'll study this in endocrine, the adrenal medulla, most authors, and I would certainly agree, is a ganglion like this that just happened to anatomically get stuffed inside the adrenal gland. You did not know where the adrenal glands are. Adrenal means adjacent to the renal or kidney. So effectively adjacent is next door, except they're on top. There are little bits of tissue on top that are extraordinarily important. So the adrenal glands here, basically that acetylcholine release triggers the equipment in there, the cells in there, to produce not only epinephrine and norepinephrine. So in that same silly model where the idiot cuts you off, think of what happens to you after it's like, oh my God. Then you had to pull over the side of the road and go, jeez. Heart's racing, you're trying to catch your breath, you're all jittery. That's the flow from the adrenaline, in the old days. Epinephrine and norepinephrine were called noradrenaline and adrenaline because they came from the adrenal gland. And that's where, and that is the prolonged feeling that we get. And depending on how close it was to something really bad happening, is probably how long it stays with you. I mean, some people, they're just, they'll come in the class, what happened? Because they're still messed up. It just depends on the severity. And a lot of people handle things differently. Lastly, the parasympathetic, okay, releases acetylcholine at the ganglion and after. So you can see they're both positive and negative. It depends on the receptor. That's the bottom line here. So these are the two arms. The maintenance and when you're conserving energy, when you're resting, is when the parasympathetic is busy. Then all the blood flow and all the energies can basically due to maintenance operations. We got to cleanse the blood. We got to process all the food and the liquids, digestive, genitourinary. The sympathetic division is there for action. So, and most organs, not all, that is an error. And I'll point out to you the ones that are not all. Most of these are served by both, but the divisions cause opposite effects. And that's where the dynamic antagonism came from. You're going to see a lot of stuff if you scroll through these, as I will, about ganglia. Don't care. They all have names. It's the type of thing we had to memorize in medical school. I mean, I would never teach it at the undergraduate level, much less as an entry-level course. Don't teach it to my advanced anatomy students. It's graduate or postgraduate type of anatomy. It's professional school anatomy. Keeps the body as low as possible, digestion, making urine, making feces. Because I don't know about you, when I get up in the morning, I usually have to go. We were convinced for years that my middle son only went twice a day, and that only if you reminded him. Thankfully, he's grown out of that at age 41. I'm very old today. My granddaughter, my eldest, is 24 today. That hurt. So you can see, relaxing. Everything is kind of normal range, relatively low, very normal or subnormal because you're not using them. It's almost like you're saving your energy. The big difference here, and we'll start to talk about it. See, typically, if you're looking at your phone, if you're typing, if you're concentrating on something else, your pupils for close work are constricted. Okay. That's the idea. And this is where we get to what the cranial nerves. I don't think you had this in lab. But effectively what happens, okay, these nerves are all about what happens. If you go to fight or flight, you dry up your secretions. Well, 7 and 9 are normally active when you're at rest. They are salivary glands. And the reason we want secretions to dry up is if you're in fight or flight, you have to have an open pain. If we intentionally cause that to occur in surgery, because as a preoperative order, you give somebody medication to dry up their secretions in case you have to intubate. You don't have to intubate for every surgery. But if they're on their back and it's short, you don't. But if you have to flip them on their side or on your tongue, you do. Because you can't maintain an airway for anesthesia. So and that's part of what are called pre-op orders, and typically the anesthetists or the anesthesiologist order. I, as a physician doing the procedure, didn't. I said, do you want me to write pre-op orders? He said, no, anesthesia does it here at our hospital. And I was working at what was part of St. Francis Hospital at that time here, because they've been absorbed. 10 is the vagus, it goes all over the place, it's the big player. 3 is the oculomotor. Remember, the cranial nerves start with olfactory, then optic, and then the third O in a row is oculomotor. If you try to memorize, it's the way to do it. And oculomotor, normally, you probably learned about it, it's the one where you're testing somebody, follow my finger, because it moves the extraocular muscles up, down, side to side. It is one of these, all have parasympathetic function, involves glandular function. This gland is called the ciliary gland. And you'll learn about it when you look at the eye in AP2. So when you're doing a physical exam, you have a pen light in your pocket. It looks just like a pen. It's got a little light at the top. There's one light. And what you do is you darken the room, would be this light, and you bring the light from the side, and as soon as the eye catches the light, the pupils are going to constrict. When you pull it away, they will dilate. And it's not just if I do this side, it's just this eye. They are equal, bilateral, and symmetrical. So this happens, both pupils will constrict. When you pull it away, they should dilate. And you get used to what's normal, and they should be equal. Well, why we do that with concussion testing, if somebody gets hit here, it's usually one side of the head, it would affect this eye. So if we say, oh, that pupil is sluggish, that gets sketchy. Now we better do some more digging about that. So we write pupils are equal and reactive. We use the acronym PERLA, P-E-R-L-A. It says pupils are equal and reactive to light, and then the other thing is called accommodation. Accommodation, you take turn the light off and say, follow the tip of that light. It's not lit anymore. You bring it close to their nose. Your eyes will point medially toward the midline to follow it, and the pupils will constrict. That's called accommodation. What happens is the pupils control the shape of the lens. You get this in eye phys. Normally for close vision, the lens is sort of rounded, convex on both sides. That points the light in the constricted pupils to the proper part of the eye, so for maximum vision. Distant, if I'm looking out there and seeing what's going on, I just saw somebody leaving out from the cafe, and I look outside and see that, my pupils dilate for distant vision. That's the whole idea of 20/20, by the way. And you get into that in phys. And what happens is that they dilate, the same muscle stretches the lens and flattens it, which is better for distant vision. It's basically how they do glasses, whether I'm nearsighted, which is much more common than being farsighted. So without my glasses, I know you're all here and I can make out the colors you're wearing, but your facial characteristics are a little blurry. Needless to say, if I'm driving, I better have my glasses on. Or I'm going to get an unpleasant greeting from the local police officer should they pull me over. So, fight or flight, all the things can trigger it. Any of these are all part of it. And again, heart rate, respiration, dry mouth, cold, sweaty skin. One of the areas that the sympathetic innervation, it's not dual. The skin is an organ. Only the sympathetic goes there. And the reason you have sweaty skin is to cool you. The sympathetic also triggers those hairs on your skin that erector pili muscle makes your hair stand on end, goose pumps, goose pimples, whatever you want to call it. Okay? Those are related. So the sympathetic goes to the skin. The parasympathetic does not, principally as a cooling mechanism for all the heat you're generating when you're so active. The pupils obviously are highly dilated. Vigorous physical activity, blood, skeletal muscles in the heart where you're going to use it. This is a big one. The bronchioles, when you get to respiratory, your trachea breaks into two main bronchi. They go into the lungs and they branch. They branch so many times, eventually they're so small you can't see them. That's a bronchiole that implies not visible to the naked eye. The muscle around them, the smooth muscle, is what gets triggered. And it can squeeze those shut. When do we see that? Severe allergic reactions, like asthma, anaphylactic shock, maybe you're allergic to bee stings or know somebody who is. That's the EpiPen. It's all related to this system. See the reason why we use an EpiPen and not a acetylcholine pen. Years ago, they didn't have the EpiPens. So there was, they had other ways of, it was not an easy way to get that to people. It was a lot more dangerous. And we still have a lot of people who are, and you'll learn about this in immune system in AP2, I would suspect. A lot of people are just, I have a stepson. We don't have a lot of contact with this older stepson. He lives on a farm, he's allergic to bees, doesn't carry an EpiPen. We have, I don't know about you, I think that's dumb. Why would you want to do that? You could, you live out in the middle of nowhere. It's not that easy to get the ambulance might take a day to get there. It would take a while. Moving on. And this is part of that system. So the difference between them, again, as I put, craniosacral and thoracolumbar or thoracodorsal, I've heard it called that as well, different regions of the core. They still get to the same places. And we'll get to the other ones that's different very shortly. The length of the fibers, long pre, short post, short pre, long post. And the ganglia, the reason these are short, the chain of sympathetic ganglia are right next to the spinal cord. You're going to see a diagram that's doesn't really show you to, but an illustration that does. And this is the diagram that isn't as accurate. It gives you an idea. Here's the parasympathetic. You have that vagus. Look how long that is. From the head and neck all the way throughout the abdominal peritoneal cavity. Only the sacral ones go to the bladder and the genitalia. And again, so they're fairly long, and they basically get into the organ, and then they trigger the next nerve to do whatever it's supposed to do. The sympathetic, very, very close to the spinal cord, and it's much closer than it's depicted here. And now you're going to see the second big difference. Everything here is the same, except here we have the adrenal gland, and they really mean the adrenal medulla. Like I said, that is, most of us feel that's just another ganglia that happens to be out of position. And all it does by way of that is release the noradrenaline and adrenaline, or norepinephrine and epinephrine, into the bloodstream directly. As I discussed, that's a significant difference here. The skin, the one that you don't see here, and but probably the most important, this is crazy why they don't have it, blood vessels. Smooth muscle. Is what blood vessels are, tubes that have surrounded by smooth muscles that will either can open up, we call it vasoconstriction, or dilate, vasodilation, right? So all of your blood flow to those areas comes from this system, only from the sympathetic. The sympathetic only there. That blood flow is what we are able to redirect the flow to where it is needed in the sympathetic, such as the muscles in the heart. And because of that, the organ that is affected potentially most dangerously and importantly is the kidney. You'll notice on these charts, nothing says kidney. That's because the kidney is just filled with tubes and blood vessels. The kidney, everybody, is a high pressure filter. If the pressure in order for it to cleanse your blood, which it does constantly, normally about a quarter of your circulation right now, all of you, is going to your kidneys. We're cleansing our blood constantly. You cleanse it, you generate urine, you concentrate it, and whenever it gets to be enough, particularly overnight, you release it. That's why we do first morning urines for pregnancy tests, or for a lot of other things. When you go to the hospital, we want the first urine because it's the most concentrated. It's not rocket science, it's what it is. The kid, with your blood pressure is how taut those vessels are. When the smooth muscle is unusually taut, your pressure is high. If you're normal, relatively speaking, or like me, taking blood pressure medicine to keep it normal, it's relatively loose. That's what blood pressure is. Your kidneys, if it gets too loose, for whatever reason, typically it's from losing fluid. Someone's bleeding externally or internally, vomiting and diarrhea profusely. Somebody gets a horrible food poisoning, okay, or a giant infection from what they're going out of both ends constantly. What that does is it lowers the volume, the amount of fluid in the system. The blood pressure has to drop. We have a word for it. When the blood pressure drops sufficiently for the kidneys to shut down, shock. That's typically what we refer to as hypovolemic shock. Loss of volume for whatever the reasons are. It's somewhat nonsense, but there's other causes of shock. Some people go into shock emotionally because they see something horrible. But if you want, the definition of shock is lack of blood supply to vital organs. The kidney is the most sensitive. The kidney has one response to anything going wrong. It shuts down. Gets an infection, it shuts down. Gets a blockage, it shuts down. Doesn't have enough blood supply, enough pressure, it shuts down. When your kidneys shut down, all of a sudden they can't cleanse your blood. Bad things develop in your blood. And if it happens rather quickly, you'll end up where I ended up 19 years ago, this past summer, in intensive care. I had an infection from food caused such severe vomiting and diarrhea, and I was not a very healthy individual in any event. And what happened is I was in intensive care for 3 months. So bad the first night that they called, I was 55, they called my 87-year-old mom, who was very kosher, and said I was close. And it wasn't close to seeing her, it was close to death. Be wary. Nothing to be joked about. And that they should put that in here. Blood vessels and kidney. Why they didn't is just a fault of whoever designs the PowerPoints. And you can look through this if it helps you. I don't think it's particularly helpful. Parasympathetic, I told you about a little bit, long and then short. Again, the same illustration. This is the big one, that oculomotor of the first 3. Again, that's all about that ciliary ganglia. Parasympathetic ones go typically to glandular structures or something that behaves like a gland. That ciliary ganglia is kind of like, when you get to the eye, and the eye dissection is a very good dissection that undoubtedly you will do. And that basically it's got this is why I don't want you to know these names. You don't really need to know pterygopalatine ganglia or things like that. 7, the facial, and 9, the glossopharyngeal salivary gland. The vagus, 90% of all those fibers all over the chest, the abdominal pelvic cavity, all these different plexes going to all these different places. Fine. The sacral is interesting, and this is really with the 2 of them. Normally they work opposite one another, and by, that's not enough, that's too much, that fine tuning, that dynamic antagonism, that's homeostasis. Where they work continue collectively, and the best illustrations in this PowerPoint at the end, so I'll comment on it again, is during during copulation. Where the arousal phase is from the parasympathetic. That leads to anything, whatever you would define as arousal. Erection, increased secretions, etc., etc. The climax or ejaculation is sympathetic. It has nothing to do with the voluntary motor system. You can't say, do this on demand. It doesn't work that way. Okay? That is the perfect of perfect example of the two of them working not quite simultaneously, but in very close proximity to one another to accomplish what we refer to as the copulatory act, sexual intercourse. And it doesn't matter. It works the same in the men and the women, even though it's defined differently. It works the same. You will get this in repro physiology, I am sure. We always teach that really very close to the end. Sometimes I have enough time to get some growth and development in, but that's an AP2. So when you see the term splanchnic, typically that has to do with the abdomen. That really is abdominal, pelvic, or peritoneal cavity. So I don't even worry about it. So you can see the sacral part, very much reproductive, but also the bladder and the ureters and even some of the large intestine. So there you can see that's not an inaccurate diagram. The sympathetic, again, the oddballs, the sweat glands and the erector pili. Interestingly, it isn't norepinephrine there, it's acetylcholine. That's an exception. And then you don't have to know anything about these rami and these paravertebral ganglia and chains. This is what I mean by close to the spinal cord. Years ago, before we had, if you're familiar with angioplasty, that's when they insert a catheter into a blood vessel that's got stuff in it like around the heart, and you inflate the balloon, and it disables, and they put a thing called a stent in there to hold it open. That's relatively modern technology. Years ago, they used to yank these out, which always made no sense to me. I scrubbed in on a couple of those back in the 77, 78, almost 50 years ago. That was because if you took out the sympathetics, remember they control blood vessel diameter. The blood vessels theoretically would widen, you get more blood flow to the lower extremity and prevent amputations. They never really worked, not at our hospital. I mean, it's a chest surgery, and so the chest surgeon came in. That was what you did in those days. It wasn't effective. We ended up doing a lot of amputations, which is never fun. Dad's cut off somebody's leg, their foot. And so you don't have to talk about the ganglia and what their names are and all that, or rami. You don't have to do that. You see, so I'm going through this. So if you see this on the PowerPoint, you can ignore it. All these different things, all these different pathways and things like that. Really not that urgent for us to do there. We're getting to the important part, which is the neurotransmitters. The adrenal medulla is the oddball, once again. So the only other oddball neurotransmitter other than acetylcholine going to sweat glands from the sympathetic nervous system is in the adrenal gland itself, the adrenal medulla. And again, this is incorrect, the way that whoever did this PowerPoint didn't proof it. Typically, the cells there secrete norepinephrine and epinephrine, also called noradrenaline, and this should say adrenaline. So it's like, do me a favor, when you're submitting a report, proofread it, have that spell check thing work, make sure you get it right. Instructors look at that and go, what in heaven's name are they doing? Don't do that. I'm trying to get there. I went right past it. So, and again, most of us consider it a ganglia that's just, for some reason, stuck in the middle of another gland. We have a lot of sensory nerves that influence it. There's a lot of areas within your organs. There's an area where the blood-brain barrier is weak. That's in the hypothalamus. Other areas, all of those internal organs have tiny sensors that are pressure sensors and chemical sensors that basically send signals. Not every system requires input, okay? They monitor these signals. They monitor these signals, sensory nerves, and basically they tell the autonomic nervous system we have nothing to do with it, whether to make these subtle adjustments, okay? And so really there's a lot of almost like reflexes, and that's really all you have to know. The oddball one is the GI tract. The GI tract is normally innervated when it's active by the vagus nerve, that long 10th nerve. It's not needed. You might surprise you to think a major nerve like that is not. What happens when you learn about digestive in AP2, it has its own nervous system incorporated into the design. It's a series of pressure and chemical sensors that when you put food in, tells it to be active, tells it to make chemicals to digest the food, chemicals to absorb the food, and you'll learn about them. Fortunately, again, I'm living proof. On 2 occasions, one in 93 and one in 2000, I had half of my stomach removed. During that time, we call it sectioning the vagus nerve. They don't just cut it, they remove a segment so it does not innervate the stomach. I had very severe ulcers, gastric or stomach ulcers, to the point where I believe me, the second time around I was in big trouble. Yeah. So 3 times I've been close. Remember, I was a relatively young man there. I was the youngest guy on that floor. In 93, I was only 42 years old at that point. And what happened, they removed that, and even though I have to eat small meals relatively frequently, I can't eat a lot because my stomach has been reduced, even though it's stretched back out a little bit, which stomachs do. It's different than having that stomach stapling or bariatric surgery for people who are chronically overweight. Probably should have told them to do that. But it really had to. Don't smile. You're terrible. So I said that to the other group. I have to eat small meals frequently. I like to frequently. I take it serious. Believe me, my wife is giving me my marching orders as soon as school is over. Once you're done with that, I expect you to be in the gym 4 days out of the week, or else. And I respect, and healthy respect for her orders. If you signed up for my micro class, I would not be here if I don't listen. So it's got its own nervous system. And so here are the big, this is the terminology as we get to we're getting closer to the end of this presentation. Acetylcholine and norepinephrine. Any fibers that release acetylcholine we call cholinergic. Any ones that release norepinephrine, because of its old term, noradrenaline, we call adrenergic. And we not only do we name the fibers by what they release, we depends on the receptor it binds to. So we call them cholinergic and adrenergic receptors. There's varying ones. You're going to have to know a few of these to remember for the exam. Same illustration you saw before. There are 2 types of these. These are found in when the preganglionic fiber, the first nerve, whether it's long or short, those are called nicotinic receptors. They're named for nicotine's been around a long time. Tobacco, they analyzed tobacco, which came to Europe in the late 1500s. That whole Spanish Armada thing was about tobacco, if you didn't know that. And so the chemists analyzed tobacco, and they found this substance, nicotine. What they did is they could mimic the activity of these cholinergic receptors, and so they named them nicotinic. Muscarine is a poison from certain kinds of mushrooms, and they named it muscarinic. So you have nicotinics and muscarinics that are there, and this is how they test it. So if you wonder how nicotine works, it basically stimulates both your sympathetic and parasympathetic system. Not necessarily equally. So a lot of times I smoked 2 packs of cigarette a day for 40 years. We would smoke, if you were keyed up, you'd smoke a cigarette to relax. Before we would take a big exam in medical school, we would all be outside chain smoking because we were getting keyed up. It works, both systems. You've never seen so many doctors who are going to be healthcare professionals doing cigarettes, but that was more than 50 years ago. Just say it. Okay, so you see they're all postganglionic neurons have receptors, and we call them nicotinic, plus in the adrenal medulla. The same, those ones in the skeletal muscle, by definition, they're nicotinic. they would respond the same way. So nicotine is very interesting, and that's as much as I can tell you. Why the addictive nature is not because of this. The addictive nature is what it does in the brain. That's the most I can tell you. It crosses the blood-brain barrier very rapidly. Why smoking is so addictive? It's about the substance, and it's about how fast it gets in, and nothing is faster than it. Nothing. Muscarinic all effector cells by postganglionic cholinergic 5. So particularly in the parasympathetic, it's the acetylcholine at muscarinic receptors. It can be both. It depends on the target. The big one that's significant, okay, is the heart. This is the one you got to remember. The whole idea of the vagus nerve, in our bodies, things go fast. Remember we talked about the cell cycle. We govern the cell cycle, because if it goes too fast, it leads to cancer. Bad cells. Your heart at rest, normally, if it wasn't for the vagus nerve, it would be over 100 beats per minute. That would be, I mean, you'd be a heart attack looking at. So a healthy heart, the vagus is very active and keeps the heart between 60 and 80. And if you're really a trained athlete in certain sports, maybe even less than that. For you young people, it should be between there. Even for me, I keep it between there. So understand that the receptor here, the oddball receptor where it's inhibitory for acetylcholine from the parasympathetic nervous system is the heart. You must remember that. So the other receptors for adrenergic, for norepinephrine, all of which is coming from the sympathetic nerves, we classify into alpha 1s and alpha 2s. We're getting close to the end. I appreciate all your indulgence. And for betas, beta 1, 2, and 3. Really important stuff. This is what pharmacology is based on. Any of you who are going into nursing or a similar discipline, if you have to take pharmacology, you're going to hear endlessly about this is a beta 2 inhibitor. This is a beta 2 stimulator. So you're getting an advantage here to understand that. So the subclass of the receptor, for instance, epinephrine, or in this case, norepinephrine going to the heart, is a beta 1 stimulant. What it does is it increases not only the heart rate, but how strongly it contracts. The flip side, the one we were talking about before from the vagus nerve, doesn't have anything to do with the force of contraction. All it does is just slows the heart rate down. You'll learn more about that in the heart. But for the time being, beta 1s increase heart rate and force of contraction. Okay. The other one, epinephrine, causes bronchial relaxation. They're called beta 2s. That's the EpiPen, everybody. So the reason we have epinephrine and EpiPen, you inject it as subcutaneous. Anybody can get that injection. If you've ever seen it. We just pop it and jam it. Okay, once it gets into subcutaneous or fatty tissue, it circulates very quickly. When someone has an asthmatic attack or anaphylactic shock, you need to, those bronchioles are so small, you can't trach them. That's not where the problem is. It's not a blockage here. It's a blockage deep inside. There's no way to open that up other than with chemicals. The epinephrine will target the specific receptors that are part in fight or flight. That epinephrine or norepinephrine dilates them. We get them to dilate if they've just had a release, as you will learn in immunology, of histamine, causing them to like that. But you see the EpiPen will bind to these beta 2s. So beta 1s, heart, increasing the heart rate and force of contraction. Beta 2s, relaxing the bronchi. That's fight or flight. Heart rate up, heart rate stronger. You need lots of air getting in and out because your heart's sometimes generating three to four times as much pumping as it usually does. It's a big deal. Nice chart about it. Nicotinics, excitation, muscarinics, excitation, the big one, the exception, inhibition of cardiac muscle. It's all about heart rate. And again, there's some other targets here. That's when you talk about the sweat gland, that's technically a cholinergic receptor. And in this case, it happens to work sort of odd in the sense that it activates the sweat production. The beta 1s and beta 2 heart, other areas, beta 2, lungs, particularly the bronchioles. If you know somebody, this isn't just an EpiPen. If you know somebody with asthma, they have an inhaler, right? That inhaler, typically called Ventolin or something similar, does the same thing. It has basically it uses a medication that will continue to dilate that. So if it's extraordinarily severe, they might have to use the EpiPen. Then typically you use the inhaler, and maybe they'll use a steroid inhaler to reduce inflammation. And sometimes they'll even take antihistamine because it's histamine mediated. And you'll learn all about that. Not a whole lot about beta 3s. Alpha 1s, blood vessels. Constricts the blood vessels, dilates the pupil of the eye, and you have alpha 2s as well. So really the alpha 1 is mostly about that. And so blood pressure medicine will often target that. There are better ways to control blood vessels today with less side effects. So they've gotten a little bit more sophisticated. So my 2 blood pressure medicines, which are very popular, don't involve this passageway. They stay away from the nervous system. Here is just some examples. So a nicotinic agent, you're addicted to nicotine, you still need the nicotine. You just want to stay away from the smoke. That's what causes the cancer. Whether or not the nicotine is harmful, we really don't know. Those people who vape nicotine to replace smoking, it hasn't been around long enough to study it. You need not a year or two, you need 20 years, 50 years to really look. How long you've been doing this? 20 years. Let's look at 20-year people who have been chronic nicotine users to see what's happening. There's a lot of people chew the Nicorette gum, used to get sores in their mouth a lot. I know some people love to chew that. It's not that you're not swallowing it, it's being absorbed with the abundance of blood vessels directly. We use a lot of medicines under the tongue. I used the nicotine patches while I was smoking. It made the smoking more powerful. I was terrible. I quit smoking with something I would never recommend called Chantix. I had dreams. I thank goodness I forget them because they were scary. I mean, I was driving here. I was part-time here. Okay, Lou, I live in my apartment. I was living in an apartment time. Okay, Lou, get ready. I'll out in the car. Get ready to make a right. You got to make a right here. Okay, make that right. Now you're straight for a while. Up at that light, you have to make a left there. I had to tell myself that. My mind was going crazy when I was taking that. For about 3 months, and I was able to stop. Thankfully. So it worked, but I never recommend it. These are muscarinic agents. We have better ways with the bladder. There's better medication today that you'll learn about. And the same thing, but glaucoma is significant. This particular medication, glaucoma is difficult to treat, and you can use this topically. So you'll learn about glaucoma when you learn about the physiology of the eye. It basically opens up the discharge channel. There's a duct that it opens up. So that's something that's pilocarpine. Now they probably use other agents now, but this was the original pharmacology. This is bad. We talked about this. This is chemical weapons, sarin, VX, like insecticides, chemical warfare. This is different. Neostigmine, very specific to the neuromuscular junction, and really this is about myasthenia gravis. And these are the terms I may have told you about, but I should have. These are terms from pharmacology that students have a difficult time with. If they mimic or they act like the sympathetic system, we call them sympathomimetic. If they fight it, they're called sympatholytic. By the same token, if they mimic the parasympathetic, we call them parasympathomimetic. If they block it, we call it parasympatholytic. I'm not going to ask you that stuff, but in pharmacology, they're going to talk about it. It's very confusing. Mimetic, what's that word? Mimics, acts like. Lytic means breaking something apart, blocks. So those are terms you should be familiar with. This is the Ventolin, albuterol. It's a sympathomimetic agent. It specifically attaches to those beta 2 receptors, so it's used a lot. I mean, some people, asthma is not a lifetime necessary thing in a lot of cases. My daughter was a figure skater for many years. And in the ice, she would get cold and exercise related asthma, short term. So she had a ventilator and one of those things. When she no longer skates, I mean, the last place she skated was here before RBU owned the rink. My daughter's 40, would be 40, you know, but she had that ventilator. I'm sure it was the same stuff. This is phenylephrine. Is if you get a typical cold pill. Most of the time, if you have a clogged nose, that's the stuff that'll be in the pill. Years ago, they used to use different medications for that. The phenylephrine is what is used today because what it will do, it will cause the dry up the secretions and bind to the alpha 1's receiver. What they did is they took its predecessor, called Sudafed, pseudoephedrine, off the market. Okay, because that was used, people made speed or amphetamines at home. There was a TV show that was very popular called Breaking Bad about somebody who kept it. It was, I mean, all that stuff between the hardware store and so they would start to track people who used Sudafed. And I was using it for an allergy pill. And toward the end, now I just take a Zyrtec. It doesn't have any of that stuff. And every time I go in the pharmacy, they say, "Okay, would you give us your driver's license? We have to record." I mean, I understood it, not a big deal. If somebody's going over there and taking their whole stock, it's a little suspicious. And they'll just notify the authorities, and you have a driver's license, you have an idea where you are. And plenty of people would do that. It was not hard chemically to do. I mean, years ago, when we were in college, the statute of limitations has expired. But there were guys I knew in the chemistry lab when I was in college, in both the school I graduated from and I started from. We call it a Beaker reaction. They had a chemical, and you just put hydrochloric acid into it and heated it, and the powder, after it evaporated, was amphetamines. Honest to goodness. Needless to say, that chemical is not available, and it's certainly not here. But it's very explosive. That's why people have to know what they're doing when they do that stuff. It's just, that stuff is bad. When it originally came out, it didn't even need a prescription. It didn't become a controlled substance until probably around the late 60s, I'm thinking. There were diet pills and things like that. I told my other class the story. Honest to goodness, exam week like this would be, in our dorm at Lehigh University in Bethlehem, PA, my sophomore year, he was like the guy who sold, like had candy. We didn't have, he had the ancestor, the microwave. He could heat stuff up. And he had a sign on his door, if I'm out, my top drawer, the greenies, which were amphetamines, so you stay up all night studying, or on the right hand side of my top drawer, just leave $2 for each one you take. Sign on the door. Completely illegal. Would have been arrested, thrown in jail for that. Drug deal. That's how pervasive they were at that time. I realize that's nearly 60 years ago. It's a long time ago. But I'm telling you, that's what it was like. Drug use was rampant. And I never did the overnighters, things like that. I hated doing that stuff. We used to stay up and listen to music and play cards with it. That's a different story entirely, but I digress. It was more recreational for me. Statute of limitations is expired. And thankfully, lastly, if we want to block them, these were the start of blood pressure drugs. We don't use a lot of beta blockers because they had more side effects than they wanted. This was the first one. It was called propranolol. So these are examples, and I believe on my review recording has what you need to know about. So this is the last part, dual innervation. So this interaction, precisely controlling it. There's always some activity of both. The only one where it's almost pure is fight or flight. So, but usually one predominant, like right now, parasympathetic predominates for you folks. Mine probably a little bit more sympathetic. So, precise control. Sympathetic increases heart, respiratory rates, inhibits digestion and elimination. Parasympathetic, the opposite. Almost all blood vessel smooth muscle is entirely sympathetic. So this division is about blood pressure, even at rest, and about the kidney, even at rest or active. Really important. We call that what your blood pressure is called. And it's a term you're going to get when we do cardiovascular at AP2, whoever's doing it with you. We call it vasomotor tone. Vaso means blood vessels. Motor is the smooth muscles, their tone, how taut or how loose they are. And they always have a tone. The bottom number of your blood pressure measures that. That's called the diastolic, what your blood vessels are like at rest. So if it goes down, they fire faster. If it goes up, they fire less, and it shunts the blood where it has to be needed, depending on what system you're using. Parasympathetic dominates the heart, digestive, urinary, most glands except for the adrenal, particularly adrenal medulla. And the adrenal gland, I guess, in general, because it's a different system, and sweat glands. Slows the heart, dictates normal activity. These organs always exhibit some power. Your heart would race. As I said, it's governed by that. Sympathetic overrides it at times of stress. Read that as fight or flight. That's a stressful time. Drugs that block that response, unfortunately, can act like it. So we have to be very careful because a lot of the side effects of drugs, not just increasing heart rate, but one of the side effects we see a lot is it's difficult, basically, to go to the bathroom. And so the best example, as I told you about before, the external genitalia, parasympathetic fibers lead to vasodilation. That's the excitability for the erection of the penis and the clitoris. The sympathetic fibers lead to ejaculation in the male and the reflex contraction or climax vaginally in the female. It's that nervous system. So people erroneously think it has something to do with skeletal muscles. It does not. It's a completely different. That's why people who are paraplegics can still have children. That system still works a lot of the times. Sometimes it doesn't work properly. That was the late Stephen Hawking, who was the most famous person with ALS. He had children, and they said, "How you're confined to a wheelchair when you could speak? How could you have children?" And he said, "It's a different nervous system." He was absolutely right. So all these different things that are there, unique functions. Body temperature rises, dilate the skin blood vessels, and activate the sweat glands. That's why it goes to the skin. When it drops, it turns it around. We'll get the kidneys. Okay, it's unique because it stimulates the kidney. If your blood pressure starts to drop, you're going to learn in kidney physiology about a chemical called renin. You'll learn about that, in endocrine, you'll learn about that a couple of times, and in blood pressure. And increasing metabolic rates. That's why that mobilizing fats for fuels is why things like speed and amphetamines and are basically are utilized as diet pills. That was that people would go in and say, oh, if they were a little, overweight, and they go to the doctors and say, I really need this help. And they give them this stuff. And then they turn around and sell it. That's what happened back then in the day. They were very easily obtainable. So parasympathetic division, short-lived. Okay. Acetylcholine goes away fast because of acetylcholinesterase. The sympathetic division is longer because norepinephrine and epinephrine take longer to break down. So that has the sympathetic, that fight or flight, that's that lingering effect from the adrenal gland that I talked about. This is the chart to take a look at with fight or flight. Dilating the pupils, okay? Inhibits secretory activity. All of those kinds of things that are there. Stimulates secretion of thick, viscous saliva, but it's not productive enough to basically stimulate sweating. So that kind of saliva, the watery saliva, blocks the passageway. The thicker one does not. So there's a fine line, but basically that's why we use it so much in surgery. Here's the goosebumps activity. Here's the adrenal medulla with epinephrine and norepinephrine, heart rate, all of those things. If you just think about what happens, that's what I always tell everybody. This is an oddball that you'll learn about with diabetes. I hope they tell you about it. Autonomic neuropathy. The autonomic nerves are affected early on in diabetics. The mechanism was never clear. They've never come up with a great medicine for it. I had 65 to 75% of my patients were diabetics. At least a third to a half of those diabetics had neuropathy. They lost sensation. One of the big signs was this, particularly in men. I had a guy, I remember to this day, he ended up needing a heart transplant, which I do not think was many, many years ago, maybe 4 years ago. When I first saw him, he was like a mountain man type. Big guy, surely 350 pounds, giant beard, big, really took up the chair. His diabetologist had sent him to me. He goes, well, she sent me there. I said, well, because I really wasn't taking my insulin dependent diabetic. And he said, I drive a truck. We drink early. They go to the local bar, shot in a beer for lunch, burger or something. Nothing, no salad bar, 8 o'clock. You know what got his attention? Why he went to the doctor and said, he had a little problem in the bedroom department. He was in his mid-30s. You know what I'm talking about. He had erectile dysfunction. It's not the kind that Viagra works on. It's his blood supply. The next time I saw him was about 6 months later, and he must have lost 100 pounds. Looked just off him. He says, I'm about done, Doc, but my doctor wants me to see you. Okay. What's going on? I'm having a heart transplant. His heart was so bad from the diabetes, the blood vessels, he was waiting a heart for a heart transplant. I never heard from him again, so I'm guessing it wasn't good. And he was a terrible candidate anyway. To give you an idea of the severity of these things. But what got his attention, if you're going into a medical field and you see somebody with that, someone who's large, someone who's early signs, particularly if they're a diabetic, whether they're taking medication or they're taking pills or whatever, and they start to describe early onset, and it's a tough question to ask, particularly for men, because men are not very forthcoming when they only address those problems when they're severe. I mean, please don't take it the wrong way. Women have babies. They very concerned about reproductive health. Men, as long as the equipment works, they're not. They don't want somebody. It's like almost a sign of weakness. The male ego gets an effect. Maybe if it's I'm not trying to say anything that's inappropriate or anything like that. It's just for a guy who's nearly going to be 75 in May. I've seen enough of these characters in my practice and in real life. So these are the other types of things. They get all of these are the types of things that happen with diabetics: blood pressure irregularity, urinary problems, impaired sweating. And to understand, someone else will teach you about this. The way to avoid that is very aggressive control early. That's proven by the Joslin Center up in that. And I think we're just about done. Yeah. Yeah, the big disorder, I would say hypertension. Heart has to work harder. The heart enlarges. Lots of different ways to treat it. This is relatively rare. This happens with spinal cord injuries. Raynaud's phenomena is very interesting. We don't really understand it. Some people get it just from cold, from sudden temperature change. My first wife got that. Sometimes it's an underlying disease. So Raynaud's, when we used to call it the patriotic disease. Normally your fingers are pink. She'd go into the pool, and all of a sudden the blood vessels go into spasm, and her fingers would turn. I remember many times coming out. So it's up because she loved to swim with the kids, particularly when they were little. And then they get sort of dusky blue because after the spasm was relieved, the blood would flow aggressively too much and almost stay in there a little bit. So they went from red to white to blue. And I'd seen a lot of those types of things in other people, and that's what they looked like. Very bilateral and symmetrical, where certain blood vessels were going, and it wasn't clear what caused this spasm. That is it. If you want to attend one of those review sessions, please do. I appreciate your putting up with me for this hour plus marathon of me talking.